Hello everyone, welcome to the safe presentation of hot cases, and this is mainly meant for the College of Intensive Care exams in Australia, New Zealand, Hong Kong. My name is Arvind. I'm a CICM examiner. I'm a specialist intensivist at Nepean Hospital, and more importantly, I'm a learner in how to make the millennial generation, the WhatsApp, Facebook people, learn effectively. Okay, and I'm going to circle learn because I teach but I want them to learn. And there's a big difference between me teaching and you learning. Now, the hot case is, as you know, it's a time trial. You have about 20 minutes. You have 2 minutes of a stem which is given about the patient, important information about the patient. And then you have 10 minutes, up to 10 minutes. You can take less than that, but you usually get a maximum of 10 minutes to examine the patient at the bedside, physical clinical examination. And then you have about 10 minutes to summarize your findings, identify the issues, and discuss. And firstly, I'm just going to divide this and into the steps of this. Step one, when you're given the stem, use the time to interpret it. Just don't read it. You have 2 minutes sitting outside the room, interpret it. Second, interpret the endobedogram, which is what I call the end of the bed physical examination. Okay, the monitors, the ventilator, the attitude of the patient, the whether they get their feeding, etc. Step three, do a focused physical examination. That's very important. You have to do a focused physical examination, but constantly keep interpreting the physical examination. Step four, put it all together. And the way you do it is, firstly, just very easy. Identify the broad syndromes. Does this patient have each organ system has only a finite number of syndromes. Okay, it's very easy, even from the end of the bed, to say this patient has this syndrome with the cardiovascular system. So cardiovascular has only 2 or 3 syndromes. It has forward failure, which is shock, backward failure, which is congestion, and electrical failure or electrical abnormalities, arrhythmias. Okay, then you have for the respiratory system, you only have hypoxemic respiratory failure, hypercarbic respiratory failure, mixed respiratory failure. Then once you identify the broad syndromes, identify a set of differential diagnoses, and then from these set of differential diagnoses, and you shouldn't have more than 3 or 4 differential diagnoses, from the set of differential diagnoses, identify 1 or 2 likely diagnoses. Okay, then step 5, identify the key issues in this patient. Now you have the syndromes, you have the organ dysfunctions, etc., but what are the issues? Okay, now a patient who has a particular syndrome, so sepsis, septic syndrome, etc., you have to say, I think the issues for this patient are sepsis with multi-organ failure, something like that. Okay, and you also have chronic issues that you may have identified either from the stem or from the end of the bed examination, and put that also into the equation. So an 85-year-old with a pneumonia itself is it becomes a big issue compared to a 25-year-old completely okay with a pneumonia, compared to a 25-year-old developmentally delayed patient who's had multiple hospital admissions for aspiration pneumonia. That is a separate issue. Okay, then specific investigations for each of these issues. So now that you have the issues, okay, suppose one of the issues is oliguric renal failure. What are the specific investigations you'll want? A, you'll say, I want the trend of urine output. B, I want to do a bladder scan or a renal ultrasound to exclude post-renal failure. 3, I want a urine analysis looking for casts, looking for evidence of nephritis or nephrosis, that kind of thing. Okay. Then, and it's only specific, go for where the money is. Talking about things like, I want a white cell count in sepsis. So what if the white cell count is up or down? It's not really going to answer the clinical question. Instead of that, say, I want a blood culture, urine culture, sputum culture, whatever, all cultures under the sun. Then, step 7, once you know what the issues are, once you know what the investigations are, now you have to start treating the patient, and again go for specific treatment and supportive treatment. Okay, specific treatment for this patient. This guy has a pneumonia. I think it's a community-acquired pneumonia. Therefore, I'm going to give this antibiotic. Okay, I think this is a hospital-acquired pneumonia. Therefore, I'm going to give this antibiotic covering these bugs, something like that. Supportive treatment. He's dying of his pneumonia, and therefore, while I'm giving the antibiotics, I'm going to put him on a ventilator and give him the lung protective mode of ventilation, something like that. Finally, anticipate the future course. I'm worried that this patient is still on a ventilator on day 13. Okay, he's still intubated on day 13. I've got to start thinking, planning ahead. If he's getting better, I might hold off, and these are the things that I'll be doing to get him better. But if he's not getting better, I'll have to start thinking of, what should I do? How can I get him weaned off the ventilator? How can I do I do a tracheostomy? Is he a candidate for one, etc. This is how you proceed. Now, interpreting the hot case stem. Okay. Now, this is just a copy paste from the stem that is given to you in the actual exams. Okay. And what now here, ignore these two things, the bed space, the examiners and all that. Here they'll give you the patient's name. Okay, so assuming it's Arvind. Okay, and they'll give you an age. So they'll say, assuming it's a 90-year-old male, and ICU day 21. Okay, and presenting problem was aspiration, pneumonia. Sorry, not they won't give you the diagnosis, but they'll say he presented with shortness of breath and fevers or something. Okay, fevers and cough or something like that. Then they'll say significant background. He is bedbound from a nursing home. He has double incontinence. He has recurrent episodes of aspiration. So he virtually lives in the hospital. He comes to the hospital every 3 hours. He gets discharged and comes back immediately. Something like that. Okay. The current status, he's orotracheally intubated. He has multi-organ failure with cardiac, respiratory, skin, bones, muscle, everything under the sun, bone marrow, everything is gone. And the question is, how are you going to progress him further? Okay. Now, what are the inferences you can make from this stem? Firstly, what is a 90-year-old man doing in the ICU? Okay. Second, especially, what is a 90-year-old man with all of these problems doing in the ICU? Thirdly, what is he doing on day 21 in the ICU? That's one question. So clearly, in the later half of your thing, you have to, in your discussion bit, you have to say, I'm really, really concerned about this patient. This is what I've heard so many candidates say. I'm really concerned about this patient. Yes, sir. I know you're concerned. Go ahead. Please tell me what you're concerned. So anyway, fine. Forget that. The style, and I don't want to comment on the style of examination or style of presentation, but it's something that I couldn't resist. Anyway, coming back. In the discussion, you have to say, I am really concerned that this 90-year-old man who's doubly incontinent from a nursing home is in the ICU now on day 21. I just don't know what we are doing here. I think it's high time that I go and talk to the intensivists in this hospital and say to them, can you all please resign, and I'm going to take your job and I'm going to rid this hospital and save the government a lot of money. Okay. Or you will say, I'd like to find out there is something, clearly something bad is going on. This is a man who's at the end of his life, and I have to speak to the family and make sure that it's all, and that something like that. So clearly end of life is going to be a big problem here. Okay. Then forget the end of life thing. Okay. Make this a 49-year-old man. Okay. Now you are still going to say he is what did he come with? Shortness of breath, fever, cough. Clearly this is a respiratory problem, and the respiratory problem is a respiratory infection. And therefore, what is the common respiratory infection that puts you in the ICU? It's not a bronchitis, it's not an upper respiratory infection. It is clearly something that is likely to be a pneumonia. Therefore, you have to go and examine. Most likely you'll be doing a respiratory examination looking for pneumonia. Second, if he is still in the ICU on day 21 and still intubated on day 21, what does that mean? It means to you that this man has not improved from his pneumonia. Why? So is it because he had really bad pneumonia to start with? So is it the same process that's going on, or are there so is it failure to resolve, or is this a new complication such as aspiration pneumonia or something else, or maybe he developed ischemic gut in the meantime? What is keeping him in the ICU? Thirdly, it says here he is still orotracheally intubated day 21. So third week of ICU, if somebody has still not done a tracheostomy, why? Is it because these guys are lazy and you need to again kick them out of a job and you take their job and do what is appropriate? Or is it because they have a genuine reason for keeping him intubated? Because maybe, he's looking excellent. He did not improve for 20 days, and all of a sudden somebody came and gave frusemide and got 25 liters off, and all of a sudden everything is improved and he's looking good for extubation, and say hi bye to you. Who knows? Okay. So these are the things that you will be interpreting from the stem. Next, you come to the endobedogram, or what I call the end of the bed examination. So when you have a patient in a bed like this, okay, you have a patient lying here, clearly unhappy. Okay, what are the various things that you'll be looking for? A, this patient is most likely, so you're going to see whether they have a tube in the throat and they have a nasogastric tube, etc. Okay, firstly, let's just go to the infusions. Okay, so he's going to have an IV pole with a bunch of infusions that you will be seeing. And these infusions, common infusions are sedation, analgesia, vasoactive agents, etc. Then you'll have another IV pole that is connected to the feeds, okay? So the NG feeds or something. Then you have a urinary catheter. This is very common. And then the endotracheal tube you have, which is attached to a ventilator, okay? And the ventilator you'll have to know what the mode of ventilation is, and then you look for oxygenation and carbon dioxide exchange and the waveforms. Okay, then you have, of course, you have a monitor sitting in a corner which has the heart rate, blood pressure, the vital signs, so the OBS, the ICP, whatever. But you also have a lot of waveforms that can give you the analysis. And finally, you actually come to the patient himself. And the patient, you may find that the patient is completely conscious and listen and smiling at you. So let's replace this with a smile. Or the patient might really be grumpy, or the patient may be sedated, or he may be moving around, he might be having non-purposeful movements or purposeful movements, all of these things. These are the things that you should see from your endobedogram. So these are the things that you'll be seeing from the endobedogram. So let's see. Firstly, what are the infusions? So we've covered all this, and this is something that I keep emphasizing. You can get so much information from what I call the hard signs. If there's a muscle relaxant, if you have an antibiotic, that's a beautiful thing, saying that they're treating him for an infection, either empirically or confirmed infection. And based on the actual antibiotic, you can think of the bug, and based on the drug, you can get the bug. Okay. And then based on the bug, you can actually think of the source of the infection. Then TPN, there are very few signs now for TPN unless you're a surgeon. Okay. And then some of the organ-specific indication, so nimodipine, octreotide, terlipressin, all of these things are giveaway signs. Okay. Then lines and tubes. Always ask what's going in and what's coming out. So both of these are extremely important. Trace both sides of the line into the body and out. And then common things are tube, feeding tube, etc., etc. And then the less common things are EVD, surgical drains, back dressings, fasciotomy wounds, whatever. Then on the monitor, the common things are, cardiovascular numbers are heart rate, blood pressure, rhythm. Look for the ECG changes. Always interpret the waveform as well. Okay, so don't forget that you can interpret the waveform with the ECG changes, the pulse pressure variation. Then if you see the SATs, then you're going to see the ventilator in a minute. You can easily say this is the, you can intelligently talk about the AA gradient. Always ask for the temperature. And finally, you finish off saying, is the trend of all of these numbers consistent is it representative for the past several hours? Something like that. On the ventilator, you'll want the mode, the oxygenation, as well as the ventilation, and also look at the waveforms. Look for expiratory outflow obstruction. Is the patient breathing on paralysis? The peak inspiratory pressure, and then you can look at the pressure waveform and get an estimate of the plateau pressure. All of these things that you can get. And you can comment, as I said, on the AA gradient. Then there are some organ-specific monitors that you may have. Okay, always interpret the numbers and the waveforms. We have already talked of the EVD and the ICP, and always ask for the output as well as the waveform. But dialysis, go there and just say, don't say he's on dialysis. What mode is he on? Is he anticoagulated? What are the various pressures doing? Access, return, and transmembrane pressures, and do you think the dialysis is going well, etc. Cardiac output monitors, CVP, piece it together. Is this patient, if the patient is on double, vasopressin of 200 200 units per hour, and the noradrenaline dose is 1000 mics per minute, and his CVP is minus 100, clearly you can say this guy is dry as a chip. I think I should take your job. I'll treat this patient better. I'll give some fluid, something like that. Okay. Then if you have things like IABP, ECMO, and all that, you are not in this 10-minute format. You are not really expected to spend too much time on it. And even if you're extremely comfortable with it, unless you have a very, very quick way of interpreting it, don't waste your time too much. Okay, do the basics and move on. Okay, and finally, finish off with the patient's general appearance from the end of the bed. And here it depends on how much of the patient's body you are actually having access to now, because you remember you haven't yet actually uncovered the patient. You're still standing at the end of the bed, and I forgot to mention, you cannot take more than 60 to 90 seconds. So 1.5 minutes will be the maximum amount of time I will tell you to walk around the bed and look for the various things, the intercostal tube, or the BiPAP machine in the corner in a patient who's intubated, all of these things, not more than 1.5 minutes. Okay. So the appearance, is the appearance of the patient consistent with the age? Are they unkempt? Do they look frail? Do you have tattoos? And this is very, very important, I find. In the 1.5 minutes that you're observing the patient, and of course subsequently as well, comment on whether the patient seems to be moving spontaneously, and is the movement purposeful or non-purposeful, going for the tube. These are nice, good signs that you can talk. Are they moving all the 4 limbs? Because that immediately rules out a gross motor deficit. Okay, and then you can look for hard signs. Is there a chemotherapy bin in a corner? Is the patient being physically restrained on one side or both sides? And that could mean that they either have a focal deficit, or they have non-purposeful agitation and going for the tube, etc. And then in a patient who is not intubated, if there's food at the bedside, clearly it means that they're eating, etc. So all of these intelligent interpretations that you can do, make the most of the information, but in a time frame that is not too much. You can't spend 5 minutes at the bedside. Also, my approach to this is to talk loudly while I am observing these things. I find that it does two things. One, it actually reinforces the findings in my own head. It helps me organize. Also, I'm actually saving time on my presentation subsequently. So and these are things that are extremely easy. They're non-controversial. You don't require a rocket science degree to interpret the fact that a patient who's getting 70 mils of nasogastric feeds. You can safely assume, I think he's tolerating his feeds. Okay. And if a patient is on 30% oxygen and saturating 200% on his pulse oximeter, you can say clearly he's oxygenating excellently. That kind of thing. So I don't read out the numbers. I don't say he has a heart rate of 43.5 and a blood pressure of 222 by minus 45. I always say he has a wide pulse pressure. Then he is bradycardic, and the rhythm appears to be sinus bradycardia with intermittent episodes of complete AV nodal block. And as I was observing, I found that he had an asystolic run for 2.5 minutes, and the nurse started doing CPR. Now I actually make these interpretations. Anyway, I think I'm just going ahead of myself. Then, at the end of the endovetogram, and this time ask yourself, what are the main organ dysfunctions or syndromes? And that's so easy. You only have a finite number of organs. You have the CNS, you have this, okay, let me draw. You have the CNS, you have the cardiovascular system, you have the respiratory system, then you have the gut, okay, then you have the hepatobiliary system, and then skin, you have the metabolic system. I'll put the metabolic acidosis, and overall you can have sepsis as one syndrome. And for so it's easy to identify for the CNS whether they have an altered level of consciousness, which is either decreased, which is decreased level of consciousness, or increased level of consciousness, which is agitation. For the heart, you can easily say whether they're in forward failure or backward failure or electrical abnormalities. So, you can say whether they're in shock or hypotension, and secondly, whether they're in backward failure or congestion. For the lungs, you only have hypoxemic and hypocarbic respiratory failure or mixed. For the liver, you can say jaundice. For kidney, you can say oliguric or oliguria or polyuria, unlikely. And for the gut, you can talk about whether they have some sort of a gut syndrome, acute abdomen, not tolerating feeds, paralytic, whatever. you have very few syndromes, and it's so easy to pick this up from just from the end of the bed. And that means you have the next step, which is which organ system should I start with? Okay. And then in your 10 minutes, if you don't have time, which organ system can I afford to not ignore, but if you don't have time, ideally you want to see all the four organ systems. But if you're not able to, because the patient became agitated in between and you lost some time, or it was a cardiac arrest call and you had to do CPR for 8 minutes. Now, which organ system? So if somebody is breathing on 21% oxygen at 10 or 12 breaths per minute and is no accessory muscle use, and the SATs are good and the EtCO2 is good, you can safely assume that the respiratory system is not the problem here. And you can either do a very quick auscultation for a wheeze or something that you can't get from the end of the bed, or you can just, in the interest of time, I don't have time, let me go to the open abdomen with about 300 drains hanging from the end of the bed, from the abdomen, and something like that. Okay. So now we come to the physical examination, and one thing I keep emphasizing is that all you need is a medical student level examination. And remember, if you're not able to do a medical student level examination, do you really think you should become a specialist intensivist? Ask yourself that question. Okay, if you don't know how to do auscultate the heart for murmurs, feel the body for low cardiac output states, for capillary refill and whatever, do you really think you should be here? Okay, ask yourself that honestly. So let's move on. Now you've done the endobedrogram. You've identified that the CNS is one problem, for example, and so you start off with the CNS. Okay. So what do you do? As I said, it's just a medical student examination. Now, you guys can actually, this link, this is beautiful. It actually, in one single page in the internet, it's a beautiful approach to physical examination of the CNS and putting things together. Okay. And again, as you're examining, you have to put things together. You have to interpret. Do not just get the findings. Now, do I talk when I do the physical examination, and do I actually give the findings? When I used to be a trainee, when I was practicing for my exams 10 years ago, at that time I did not. I used to voice loudly during the endobedrogram because the findings I found were pretty incontrovertible and easy to interpret. When it came down to the actual physical examination of the organ systems, I did it silently because I wanted to assimilate the findings. However, as I've been doing this multiple times, I find that even for this, as I'm doing it, if the reflexes are down or if the plantar is up or something, if voicing it and stating the findings once again is actually not a problem, and it does the same thing, it reiterates the findings for me. Secondly, even if I forget to mention this in my actual presentation subsequently, because the examiner has seen me doing it and heard me interpreting it, I still will end up getting marks. Okay. Again, all of these things are what works for me. You guys can decide what works for you. Okay. Especially if you're sitting the current exams, the upcoming exams don't change anything unless you're woeful. And if you're woeful, you actually have to ask yourself, am I ready for the upcoming exams, or should I postpone? For people who are sitting the exams more than several months away, 6, 7, 8 months, I suggest you practice doing it loudly and making intelligent inferences, because it will actually save you both time and it might give you some extra marks. And remember, in the exam, time is money. The more time you save, the more time you have for the examiner to ask you questions, the more marks you're likely to get. Anyway, going back to the CNS examination. Firstly, it's what are the various things? You talk about higher functions, cranial nerves, motor system, sensory system, cerebellum, etc. Higher functions, which is cognition, you start off, are they sedated? Okay. And if they're sedated, then obviously you've got to tie that together. And then you talk about alertness. Okay, is the patient alert? And then if they're not alert, then you give a graded level of stimulation. I feel infuriated when people when a patient is just lightly sedated with a RAS of, with a Richmond score of 0 to -2, quite appropriate level of sedation, and people go and want to give painful stimuli. It just riles me. Okay, I hate it. Go and ask, just call out, And it's important to establish the level of alertness and the level of sedation, for example, or the level of consciousness, and ask, is the patient alert even without you looking around, or is he rousable to voice? Firm touch, just shake the patient a little bit, and say, excuse me, are you, Mr. Smith, are you okay? Can you open your eyes for me? And then you say, he's not doing anything, I'd like to give a painful stimulus. And now I can say, okay, you've tried your best to wake these people up. He's probably a politician, therefore, you'll have to give him some pain to wake him up. Okay. Now, if the patient is awake, on the other hand, you actually have to find out if they're oriented or obeying commands. And if they're non-intubated patient, you ask, where are you, time, place, person, etc. And ask the most difficult question. Do you remember Donald Trump's tweets from yesterday, or do you know who the Australian Prime Minister is? And this question always stumps them. Or if they're intubated, then you can ask them to do complex things. You can actually say, okay, can you move your right forefinger 323 times for me, please? Okay, can you touch, seriously, you can actually ask them to do relatively complex things. You can say, can you touch your nose? And that immediately tells you that they have anti-gravity muscle power and they can understand you, and they're clearly obeying commands and they can process the information. Okay, it does. Okay, so assess that they can move all the four limbs if they're awake. Then that immediately tells you whether you have a problem in one limb or the other. Cranial nerves. Okay, so and this is just from the end of the bed. Sorry, not the end of the bed. Just this is so far you haven't touched the patient. You're just talking. Cranial nerves. Now, for all patients, including unconscious patients, you have to do pupils, corneals, cough, and gag. Now, with regards to cough and gag, you may not do it. You can say, I'd like to do it. And often the examiners will say, okay, yes, he has a cough, or yes, he has a gag, or no, they'll bail you out. But you should ask. Okay, and if the patient is and if you're asked to do it properly in an unconscious patient, ask for a tongue depressor and do the gag reflex on both sides of the uvula, etc. Okay, and this is something you have to practice in your ward round, obviously, as well. Then if it's a conscious patient, then you have to do other tests, because if it's a conscious neuro and a conscious neurological patient, you have to practice. Okay, you ask your neurology advanced trainee about a conscious neuro patient with either focal with interesting signs, and go and examine, do enough of them, because in the exams, if there is a patient with conscious neuro with excellent findings, don't be surprised if the examiners want to keep that patient in the exam for you as a hot case. Don't complain. Okay, then the motor system, very simple. It's just bulk, tone, power, reflexes, clonus, plantars. Again, medical student level, and a broad pattern. You have to look for pyramidal versus extrapyramidal versus cerebellar, and you want to look for whether it's an upper motor neuron pattern or a lower motor neuron pattern. This is what we teach medical students, and if you can't do this, I'm sorry. I think go back 10 years and go back to medical school. Then, in special situations, you might need to do a sensory exam or a cerebellar examination, and maybe in spinal patients, or when you have a particular pattern of weakness with hypotonia, hyporeflexia, then you might have to ask for fast pointing and dysdiadechokinesis and all that. Okay. And when you have inconsistent findings, and this is something that I'm going to reiterate in every organ system, it is not unusual for you to have a mix of findings, upper motor and lower motor, or something which is seen on the right side but only on 3 limbs and not on 1 limb, etc. You have to try and A, acknowledge the findings, and B, try and give a rational explanation for these findings. Don't just brush it under the carpet. And then you have an overall summary, and you can say, the patient is sedated. I have attempted to examine this patient with this level of sedation, and therefore my findings are going to be biased. If possible, I will stop sedation, but I can understand that the patient is trying to get up from the bed and beat you up and punch you in the face. Therefore, I can see why you're giving him 125 milligrams of morphine and Midaz. I'd probably do the same thing. Okay, something like that. Give an overall summary, and then you say, CNS examination is normal, or it is clearly abnormal, with altered level of consciousness, with focal neurological findings, with an upper motor neuron pattern of the left side, which is these findings, and that means I think he has a left-sided hemiplegia or something like that. Then you say, I could not really examine the sensory system, but when I gave a painful stimulus, he did respond. He did, wake up or whatever. I didn't do a cerebellar examination because he's unconscious, etc. And these are my inconsistent findings. These findings I really couldn't piece together. So this is how you just you put everything, you give an overall summary. And at the end of it, at the end of the summary, you should have some syndrome of CNS. Okay, and I'll come to the syndromic CNS in a minute. Now, these are my broad differentials for common neurological syndromes, okay? And the broad neurological syndromes are altered level of consciousness, which is decreased or increased level of consciousness. And you can have focal neurological deficits, okay? And for decreased level of consciousness, and the things in bold are more common, okay? Then you always have to talk about sedation or any other CNS medications. If somebody has taken a psychotropic medication, etc., an overdose or pregabalin or something like that that's hanging around. Then you talk of structural brain disease versus non-structural brain disease. These are the two broad things. And then you talk of brain disease, and you talk of structural brain disease versus non-structural brain disease. And then the other broad thing is systemic. So non-CNS, so CNS versus non-CNS, and under CNS you talk of structural versus non-structural. Okay, so let's talk of the CNS causes. Under the CNS causes, the structural causes, what will make you comatose or unconscious? It has to be something pretty big. So you need to have some form of a mass effect, either from a bleed or a large ischemic stroke, or bilateral cerebral hemispheres, so bilateral cortex, etc. It has to affect the reticular activating system on both sides, or the corona radiata, or something like that. Okay. Then you can have a posterior fossa mass effect. So you can have a posterior system bleed, posterior fossa bleed, or something like that, or a cancer or something, or tumor, sorry, not cancer, tumor or something. Or you can have a brainstem ischemic stroke or a brainstem bleed. I forgot to mention the brainstem bleed here. Okay, that's here. Then the non-structural brain disease, which is here, will be seizures or infective causes, meningoencephalitis. Then you have systemic causes. So the systemic conditions can include severe sepsis, so these things here. You can have infection, then organ failures, hepatic encephalopathy, uremic encephalopathy, etc. You have to have severe fluid and electrolyte derangements, okay? Electrolyte derangements. And which electrolytes cause a problem with the CNS and cause unconsciousness? It has to be sodium or calcium or glucose. Nothing, magnesium and potassium and phosphate, they don't really cause unconsciousness or altered consciousness. Of course, acidosis, severe acidosis. And then you can have very severe endocrine disorders, which are hypothyroidism, hypocortisolism. They're not common, so that's why I have not bolded them, but in a patient, you have to give them as a differential diagnosis. And finally, you can have drug effect, both giving drugs, which we have covered here, or drug withdrawal states can sometimes cause, I don't know whether it causes coma actually. I would say drug withdrawal will cause more of agitation. I've just put it here. If somebody can come up with a drug withdrawal state that can cause coma, then good on them. And then altered level of consciousness on the other side, which is agitation. And again, bold is more common. And always have this acronym, PAD, pain, appropriate agitation, and delirium. You have to exclude this in this order. It has to be in this order. If I keep pinching you and then I say, oh my God, this guy is agitated, I don't know what's wrong. You'll say, stop pinching me, stop irritating me, stop giving me these questions and asking me to create vivas and answer questions and all that. Obviously, you are in pain or you're appropriately agitated. And if you rule out both of these things, then you can say maybe this is delirium. Okay? Then non-purposeful agitation, again it's the same thing. So it's the structural brain disease versus the non-structural brain disease, and then you have the systemic conditions. It's just that the list is slightly different here. There are a lot of things from this which are similar. Okay? And in fact, most things can probably cause one or the other. So what are the structural brain diseases that can cause? Always rule out focal versus non-focal neurological deficit, and that and again that includes that's something for the coma patients as well. You always have to make sure that they don't have a focal neurological deficit. For example, if you have a comatose patient with an absent corneal reflex on one side, clearly you have to say, okay, I'm worried that the brainstem has a problem. So always, so even always rule this out on both sides. So focal deficit versus non-focal, and then you are left with intracerebral hemorrhage, stroke. So if you have a small intracerebral hemorrhage or a small stroke, which is not causing coma, but it causes, it just causes the guy to be non-purposefully agitated, or meningoencephalitis, and various different systemic conditions, it's exactly the same thing as we saw here. Okay, so that's all. So once you identify that this guy has a neurological syndrome, then you go to all, is it what sort of it here is, and then you talk about focal versus non-focal, so no focal signs, and then you just come to this thing, which is CNS, which is structural versus non-structural CNS diseases, and then non-CNS causes, which are systemic causes. So easy, so easy. Okay. Okay, so now we finished the CNS, including summarization of the findings, and then getting the interpretation of the syndromes, etc. We'll now move to the CVS. What are the various syndromes that are there in the CVS that you have to look for? Grossly, you have forward failure, which is, for want of a better word, I want to call it shock. Then you look for, under the peripheral examination, you look for right-sided congestion, and in the auscultation, you look for left-sided congestion, which is pulmonary edema. So from the end of the bed, sorry, in the peripheral examination, what are the signs of shock? You palpate the peripheries and see whether they're warm or cold. You look for capillary refill time, although I think it's worthless, but you have to put on a show and do it. And then you remember you've already done the end of bed examination. So always integrate that. So in the end of bed, if you found that the CVP was, it was 2, and the cardiac output monitor showed a cardiac index of 0.5 liters per minute per meter square, then you can say he clearly has a low cardiac output state with with a low CVP that suggests hypovolemia, and the peripheries are really cold and capillary refill time is prolonged or whatever. Okay. Then for peripheral examination, you're mainly going to look for left-sided congestion. It's only when you're coming to auscultation that you can do the left-sided congestion, so the pulmonary edema bit. Okay. But so for right-sided congestion, what do you look for? All you're looking for is pitting pedal edema, or pitting, not just pedal edema. You're looking for generalized edema, JVP, whether it's raised or not, and then you look for hepatomegaly, hepatojugular reflux, ascites, and so on. And in the end of bed, you've already got the CVP, or the JV, or the PA wedge pressure, or the cardiac output monitor, or the stroke volume variation on the arterial line, the pulse pressure variation, sorry, on the arterial line, or the stroke volume variation on the cardiac output monitor. Put it together. Okay. Then the special things, you'll talk of arrhythmias, you'll look for things for suggestion of endocarditis or chronic hypoxia with cyanosis and clubbing and all that. So this is from the peripheral examination. Then you go and start precordial examination. And under precordial examination, once again, you do inspection and palpation, and then you do auscultation. So inspection and palpation, what do? You look for scars, you look for drains, etc., and look for the output, ask for the output from the drains, and then you make a show of looking for the apex beat, whether it's normal or displaced. Okay, and most often I say I'm not really able to see the apex beat very well. I'll palpate for it, etc., so I'll just make up something, and then you look for obvious visible pulsations and so on. Then when you start auscultating, here's where you have to say the heart sounds appear normal, or I could hear a prosthetic valve heart sound. And then you talk about systolic murmur versus diastolic murmur, and for each of these things you'll talk about where it's heard best, whether it's pansystolic, ejection systolic, or mid systolic, or mid diastolic, not mid systolic. And then you look for whether it's radiating to the axilla or the carotid, and in this instance, sorry, not it's whether it's where is it best heard, etc. Then you always feel for a parasternal heave and thrill, and this is for pulmonary hypertension. And then you auscultate for left heart failure for diffuse lung crackles. Okay, that's how you do the CVS examination. So simple. And how do you give your summary of the endopedogram plus your physical examination of the CVS, you have to say patient is hemodynamically stable or not stable, on or off vasoactive agents. Okay, there is evidence of systemic hypoperfusion, namely, as I said, peripheries were cool, the JVP was low, the CVP was low, the cardiac output monitor showed this, and then I could hear I could hear it was sinus tachycardia and the low blood pressure and the stroke volume variation, all of these things. Then there's no real evidence of right heart congestion, so there's no pedal edema, etc., etc. And then, of course, I saw that he's had a fresh sternotomy, and so I've been told he's come from there. And from the stem, you have to say it'll say day 1 post-op or day 2 or whatever. So you can say, I know he's had cardiothoracic surgery. I was told he had cardiothoracic surgery yesterday, and I saw 4,555 mils of red hot arterial blood in the drain and on the pillow and on the bed and on my shoes and everything, and I think he's bleeding actively, and I think you need to call the surgeon straight away. Okay, something like this. Okay, then next is precordial examination is consistent with, I think he has an aortic stenosis murmur. Okay, remember these two things are very rare, so you're not really going to get into this. But mitral stenosis murmur, and then you can say, I think he has also, or he has clinical signs of aortic regurgitation, pulmonary regurgitation, etc., in terms of these murmurs and so on. Okay, this is obviously going to be very rare. And then you can say, I think there was also evidence of pulmonary congestion, namely lots of crackles, and he's hypoxic on the ventilator, and the compliance on the ventilator is poor. And I could see pink frothy secretions being suctioned on the endotracheal tube every 10 seconds. Okay, and then there is evidence of pulmonary hypertension, namely, he has a paroxysmal heave, precordial bulge, loud palpable P2, loud pulmonary murmur, etc. But I couldn't understand, there were some inconsistent findings. I couldn't understand why he's not on inotropes or vasoactive agents or whatever. I don't understand that with a blood pressure of 40/30, why he's on a huge whopping dose of sodium nitroprusside. Maybe that's the cause of your hypotension. Maybe if you stop it, his hypotension will get better. Something like that. Okay. Now, once you've got this, how do you go to the next step forward? What are the causes for each of these things? What differential diagnosis will you think of? And here's where, okay, when you have a shock state or a hypoperfusion state, you'll say easy, preload, afterload, contractility, obstructive, shock, and heart rate or rhythm problems. Okay, so for preload, you always say hypovolemia, which can be absolute or relative. Okay, and if it's absolute hypovolemia, you always have to say, I'll rule out hemorrhagic shock. Okay, and then you'll have to say, has his oral intake or IV intake been less? Have we not given enough? Or increased output? And just think of the various ways a human being can lose fluid. They can vomit, they can have diarrhea, they can pee it out, they can have insensible losses all over the body or burns or something like that. They can have a stoma from which they have a large stomal output, all of these things. Okay, very, very few ways where a human being can lose fluids, and you just say, I think I'm going to look for all of these things. On history and physical examination, I couldn't find any stoma. I've asked for diarrhea, and you said no, his urine output is not polyuric. Therefore, I think maybe his nasogastric aspirates are high. Maybe he has a bowel obstruction, or maybe he has a whopping distended abdomen. Maybe he's third spacing, and that's the cause of your hypovolemic shock. Then, afterload. Okay, I'm going to come to afterload at a later stage. Okay, preload, and then you talk of cardiogenic. You can have myocardial causes, and I'll have, I saw the ST elevation on the monitor, and therefore I'm worried about whether this is an MI and so on. Then you'll have to say the other causes of stroke will be obstructive shock and tamponade PE, pneumothorax. These are things that come to mind. His heart rate and rhythm seem okay, so I don't think that's a problem. And then as a diagnosis of exclusion, I think afterload, he's warm. Therefore, I think this is some form of vasodilatory shock. And given that he has a temperature and he has pus coming out of here, I think it's septic shock coming from this particular source, etc. Okay, or spinal shock or anaphylactic shock or vasoconstrictive, which is, I don't know, maybe I know he's on neurogenic shock. I know he's had a subarachnoid hemorrhage. And sometimes patients with subarachnoid hemorrhage can develop either Takotsubo cardiomyopathy, which will be cardiogenic shock, or can have severe neurogenic shock and so on. So these syndromes you have to think about. Then when you have a syndrome of peripheral edema, then you have to think of the heart failure, which can either be biventricular failure, because if you have left heart failure, why should it cause peripheral edema? It'll only cause it if you have backward congestion through the right ventricle as well. So when you have biventricular failure, or you can have the left heart is fine, but the right heart is the problem. And when you have a right heart problem, you always have to think, this is lung disease I'm dealing with. Okay, cor pulmonale. Or you can have the heart may be fine and the whole thing might be a hypooncotic state, which can either be because of severe hypoalbuminemia or liver failure, renal failure, fluid overload, and so on. And then the next severe syndrome, which will also come in the respiratory system, which is hypoxemia. And when you have hypoxemia, you have to, obviously you have to rule out left heart failure causing congestive failure. And of course, you have to rule out lung problems. So pulmonary, you have pulmonary alveolar disease. So this is going to be the common algorithm for hypoxemia for both heart and lung. So pulmonary edema, because can be caused by either LV failure, or you can have non-cardiogenic pulmonary edema because of all of these causes. Uncommon, but you have to think about. So when you say pulmonary edema, don't just say pulmonary. Even from now, when you're practicing, you say acute cardiogenic pulmonary edema, because as soon as you mention the word cardiogenic, you'll suddenly think, oh my God, I've said cardiogenic, but I haven't ruled out non-cardiogenic, because this guy, his blood pressure was 200 by something. How do I know that this is not because of bad diastolic heart failure, or because of malignant hypertension, or because they've I saw that there was a chest tube, there was an intercostal tube with 6 liters of pleural effusion. Who knows, maybe this was re-expansion pulmonary edema. Okay, then the other hypoxemic syndromes will be some form of shunt, which can either be pulmonary shunt, or it can be cardiac shunt. So for example, you can have pulmonary shunts most commonly are because of infections from pneumonia, non-infective causes from atelectasis, pulmonary embolism, or COPD. And then you have the cardiac shunts, which are right to left shunts, which can be intracardiac or extracardiac shunts. And finally, you can have artifactual. So the patient is actually not hypoxemic, but the measurement on the pulse oximeter is wrong. Things like methemoglobin and so on. Okay, these are all when you're coming down to these things. These are not really common in a fellowship exam. These are going to be the far more common causes. Let's move on to the physical examination of the respiratory system. What are the various problems you can have from the peripheral system exam of the respiratory system? You can have some signs of chronic hypoxia, such as cyanosis, clubbing, nicotine staining, causes of all of these things. And then you can also have, see features of right-sided congestion, which is, exactly the same thing as for the heart. And on the chest examination, again, you inspect, palpate, percuss, and auscultate. Okay, just medical student level, except it's more focused and more slick. And again, you look for the same things on inspection palpation. You look for scars, drains, and you look for drain output from the intercostal tube and so on, swing, bubbling, and all that. And then look for chest expansion, vocal fremitus, and tactile fremitus, and stuff like that. Things that you don't do regularly, but you have to get into the habit. And then percussion. Is it normal? Is it dull? Is it stony dull? Is it hyperresonance? Does he have a whopping large pneumothorax and so on? Another auscultation is very simple. Is it normal, or are there any extra breaths, so bronchial breathing or wheeze or crackles and so on? Okay, always look for accessory muscle use. I haven't mentioned this here. Accessory muscle use. Okay, and this is something that we saw from the end of the bed. And the comfort of respiration, paradoxical breathing, ventilator dyssynchrony. These are things that you always have to look for. Then, summary of the respiratory system assessment, integration with endobardiogram findings. You have to say, I found that the patient has fever. The nasogastric output is extremely high with phlegm. Sorry, not nasogastric. What am I saying? He has a lot of sputum, which is purulent. He has a fever, and he has bronchial breathing, etc. So I think he has something like that. So fever, scars, dressing, and all of these things. And then I found that he has a large AA gradient with a very poor compliance, and the waveform was consistent with expiratory outflow obstruction. So I found on the auscultation that he has a wheeze, and therefore putting these together, I think he has Clearly he has bronchospasm or something like that. Okay, and then the patient is breathing on SIMV mode of ventilation and is looking comfortable or looking uncomfortable with accessory muscle use, with paradoxical respiration and so on. Okay, the chest expansion is grossly reduced on one side. The chest examination is normal anteriorly, because you have to ask for examination of the back, but often they'll say no, the findings are very similar. Or you can say there is clear evidence of consolidation or collapse with bronchial breathing on the left side, or there's a pleural effusion with stony dullness on the right side. And then I can see hyperresonance with reduced breath sounds, and therefore it's a pneumothorax. And there's also evidence of pulmonary edema with a wheeze or something like that. Okay, for each of these things you have to say the findings, and then the inconsistent findings. I thought there was a pneumothorax on the right side, but the mediastinum itself, the trachea is deviated to the left. So I'm not really able to put, sorry, the trachea is deviated to the same side, so I'm not able to put it together. Something like that. Now again, a broad differential diagnosis for the common respiratory syndromes, hypoxia and hypercarbia. Okay, so hypoxia will be, you'll have to think of, is this, we've already covered this under the cardiovascular system. For hypercarbia, clearly the patient has a reduced alveolar minute ventilation, which can either be because of a total minute ventilation being reduced or dead space ventilation being increased. Very rarely you can have an increased production of carbon dioxide, but even then, for that level of carbon dioxide, they have a relative decrease in the minute ventilation. Okay, so reduced alveolar minute ventilation will be uh, the reduced alveolar minute ventilation can either be because of total minute ventilation, so either the tidal volume is reduced or the respiratory rate is reduced. When will the tidal volume be reduced? The common causes for this could be neuromuscular weakness, large pleural effusion causing restriction of expansion, obesity causing the same thing, restrictive lung diseases, and then you can have baby lungs because of ARDS and so on. Then respiratory rate. Why should somebody be bradypneic? And commonest reason will be drugs like opioids, but also you can have central sleep apnea or brainstem problems and so on, where the respiratory drive is reduced. Okay, or you can have a good normal minute ventilation, but the dead space ventilation is increased. So VQ mismatch with a VQ of more than 1. And here, what are the problems? You can have severe tachypnea, so very, very high respiratory rates, which are ineffectual breathing, so lots of dead space ventilation or conducting airway ventilation, or PEEP problems. So you can either have increased PEEP because of increased set PEEP or extrinsic PEEP that you have set, or intrinsic PEEP which the patient is generating, which can be because of dynamic hyperventilation from asthma, COPD, and so on. Or it can be because of pulmonary embolism, although PE should usually cause hypoxemia. And when the patient hyperventilates, often the carbon dioxide becomes normal or reduced. But I have seen patients with pulmonary emboli where we've actually thought of it because the PCO2 was very high and we couldn't get any other causes. So we've thought, okay, could this be because of an increased dead space ventilation? Maybe that's the cause. And we got, and I've been surprised sometimes. Of course, some very rarely you can have increased production of carbon dioxide, really hypercatabolic state from burns or something like that, or maybe the dietitian has come and fed the patient at 200 mils per hour, and producing lots of carbon dioxide. Then you do a medical student examination of the abdomen. Okay, what are the various broad acute syndromes you'll be looking for in intensive care, and one of them is chronic liver failure signs, and the other is either an acute abdomen or actually a surgical abdomen. And easy, again, as I said, medical student level. What are the features of chronic liver failure? Okay, you look for finger clubbing, contracture, Dupuytren's contracture, palmar erythema, scleral icterus, etc., etc. Just and then integrate that with the endobedogram, because you would have seen a lot of these signs on the endobedogram as well. What evidence of surgical abdomen do you have? Obviously, or acute abdomen. An acute abdomen will always be distended, and there might be some bruising. The patient may already have had surgery. If there is a drain, always ask where is the drain and how much is coming out of the drain, and what is the trend of the output from the drain, the vac dressing. Then what's coming of the upper end and the lower end, so the nasogastric tube and the bowel output, and always ask what the urine output is and what are the trends of everything, not just the snapshot, and back dressing and so on. So special things here will be all of those things. And then when you do an abdominal examination for palpation and percussion, you confirm the inspectory findings, and then what are the you look for evidence of a surgical abdomen here, which is you look for guarding, rigidity, rebound tenderness and rebound tenderness, and where is it maximal? Is it focal or diffuse? But always be gentle. If you're not gentle, your examiner will not like you. Okay, because what might happen is the patient might withdraw consent for the next candidate, and then the examiner has to scrounge around and find another patient, and they have to examine the patient and find all the findings and think of the questions, and that's something. When you create work for the examiner, remember, that's not nice, that's not good. Keep me happy and you'll be happy. Anyway, so that's the surgical abdomen. Hepatosplenomegaly. Okay, if the patient has hepatosplenomegaly, just think, this is where you get the general physician in you. Okay, you're not just an acute care physician. What are the causes of hepatosplenomegaly? Is this something from backward heart failure, right heart failure? Is this an early hepatitis, early cirrhosis, or cirrhosis doesn't really make sense because the liver will be small, but maybe in the early phases and so on. Or am I actually dealing with something like a lymphoma or a leukemia with infiltrates, and therefore should I go and examine the cervical lymph nodes for lymphadenopathy, or is this a viral infection like infectious mononucleosis, or that's you have to activate the intellectual part of you. And then of course the patient, if the patient has ascites, then your job will be to get the ascites and auscultate and get it. There's very little auscultation to do in the abdomen except for bowel sounds and the special things. If the tendon is in the flank, then and there's frank pus in the urine or something like that, do a renal angle tenderness and so on. And the summary of abdominal assessment, you'll have to integrate. So you have to say, I found that the abdomen was distended. There was a whopping big scar. There is clearly a midline laparotomy dressing. I found 18 drains in the abdomen, each of which was draining, one of which is draining frank pus, the other was having frank blood, the other was having frank bile. The urine output was next to nothing, and I was told that the nasogastric output was 800 mils per hour and the bowels are not working. So clearly there is some problem there. And then I went and examined the abdomen, and I found that this patient has evidence of chronic liver disease, namely this and this and this. And this is where I said, if you actually are smart and you get these, you talk about these findings already when you did the examination, you'll save yourself a bunch of time, and you can say, clearly the patient had chronic liver disease, the findings that I've already listed when I examined. And then he also had features on acute abdomen. Again, I've listed the findings before. Okay, and the renal system, the urine output was normal, but I do have to get the EUCs or the urea creatinine and so on. Or the patient was having oliguria, and I found a dialysis machine where they were taking, and this was the mode of the dialysis and so on. But I couldn't find, there were some inconsistent findings. I found he was bleeding out from here, but he's also on heparin, and I couldn't see any evidence of protamine. Are you sure you're doing the right thing? That kind of thing. What are the broad differential diagnoses for the abdominal syndromes? Okay, here. Large nasogastric aspirates of feed intolerance, always rule out acute abdomen, mechanical obstruction, and paralytic ileus. For diarrhea, it could be infective, overflow, sometimes drug-induced, osmotic diarrhea, malabsorption, and ischemic gut or something if you have a bloody diarrhea. Abdominal tenderness or acute abdomen, is it localized or diffuse? Always rule out peritonitis. And then, or the various itis, pancreatitis, hepatitis, cholecystitis, nephritis, colitis, etc. Jaundice, is this a biliary tract obstruction? Or it could be an intrahepatic biliary obstruction and cholestasis, and always think of drugs in this. Or could it be some form of hepatitis? Is it congestive hepatitis, ischemic hepatitis, or viral hepatitis, or drug-induced hepatitis? Then is this an isolated jaundice? So, is this hemolysis, extravascular, intravascular? Or, I found that the patient was extremely pale. So I think I'm worried that this jaundice patient is also anemic, so I'll want to rule out hemolysis and so on. And then as a diagnosis exclusion, finally, you can say maybe this is something like Gilbert syndrome, which is actually not uncommon. When the broad diagnosis for renal syndromes, the commonest renal syndrome is oliguria, and always rule out post-renal, pre-renal, renal, and sometimes you can have a non-renal cause of oliguria. Post-renal cause, you'll have to say, I'll have to get a bladder scan or an ultrasound or a CTKUB. Then pre-renal, is it because the heart is the problem, so the patient has a low cardiac output state or has hypotension, or maybe the patient has an abdominal compartment syndrome or something like that. In the renal problems, it can either be a glomerulonephritis or a nephrosis or tubulointerstitial. And then finally, non-renal, you can have ADH secretion, which causes appropriate oliguria. He's only day one after a thoracic surgery or something like that. So what if the urine output is 20-30 mils an hour? It will settle down. I'll just get the urea and creatinine, and if the urea and creatinine are fine, I'm going to hold tight. He looks eubulemic from the end of the bed, so I don't have a big problem. Or it could be inappropriate ADH secretion, so the syndrome of inappropriate ADH secretion, you can only confirm by getting a urine and serum osmolality and so on, okay? Polyuria is the other renal syndrome, but this is not common. And if it is present, it's almost always because of diuretic use. But sometimes you can have inappropriate polyuria not because of diuretic, and you have various different syndromes for that, which you can only piece together by doing a paired osmolality of the serum and urine. So if both serum and urine osmolality are both reduced, so it's a dilute serum and a dilute urine, clearly this patient is having an appropriate diuresis, and that's because either the patient or you have given excessive water. Okay, so they're just peeing it out. If the patient has an increased osmolality of both serum and urine, what is happening here is that they have a concentrated serum and a concentrated urine. Sorry, this should not come here because the patient will not be polyuric, the patient will be oliguric. Okay. But very rarely, of course, you can, sorry, very rarely, sorry, it can be here. Very rarely the patient can have a hyperosmotic solution being peed out, and that can be glycosuria, mannitol, ethanol, contrast, and so on. Okay. Then the next thing is this is the inappropriate ADH related problems. You can have increased serum osmolality, so concentrated serum, but dilute urine, which is decreased urine osmolality. And so this is inappropriate diuresis of free water, and it can either be because of diuretics, you'll have to check it out, or you can have diabetes insipidus, which is reduced ADH or ADH deficiency. Now, putting it all together, this is where a lot of people have problems, and it's actually extremely simple. This often separates the men from the boys, or I'm going to be politically correct, the women from the girls. Okay. And how can you make sure that you don't mess this up? Because you've done all the hard work so far. You've got the findings. You've interpreted the findings. Now you have got the syndromes. And after the syndromes, you've actually got the differential diagnoses as well. Okay. Here's where you go to the next level of piecing together the differential diagnoses into the various different patterns for the actual diagnoses and getting the issues for the patient. So let's see. Step 1, you've identified the key syndromic issues from the stem. Don't ignore the stem, okay? That's why you've been given some history for that. The endomedogram and the physical examination. This is dead easy. As we have seen before, each organ system only has a handful of acute syndromes. So if as a doctor sitting the fellowship exam, you can't tell me that this patient is unconscious with no focal deficits, with a no motor system examination, therefore I don't, and cranial nerves are fine, And therefore, I don't think that I think the differentials for this will be structural versus non-structural, CNS versus non-CNS, structural versus non-structural. He has a fever, and I'll be thinking of a meningoencephalitis and systemic problems such as sedation and so on. If you can't do this, you shouldn't be here. Step 2, think of a diagnosis, and to be safe, think of a set of differential diagnoses. And again, all this requires is common sense deductive logic. And the problem with common sense is that it's not common. It's uncommon sense nowadays. Go back to basics, and again, it should make sense to you. There are only a handful of common differentials for the acute syndromes that you have identified here. Step 3, acknowledge and reconcile inconsistencies that you may have uncovered. Do not be defensive. Don't be afraid. If something doesn't make sense to you, despite careful consideration, maybe it doesn't make sense to the examiner either. And also, when you actually start acknowledging something, you'll suddenly find, oh, I'm sorry, I think it actually makes sense. I think this is what the problem is. Bring in the subacute picture and the chronic issues from the stem, okay, and the age of the patient and the chemotherapy bin that you may have seen, etc., and the lymphadenopathy that you may have seen. Bring that into the picture, and finally qualify all this by saying, this was from the end of the bed. This was a physical examination. I need to do some appropriate specific investigations for these. And I've underlined specific because I don't want shopping list for the investigation. I only want you to limit yourself to a maximum of 3 or maybe 5 specific investigations. And if you're not able to do that, it means you're waffling. And you must become good enough on the day of the exam to do this during the hot case on the fly. If you're not able to do this during the hot case as you're examining, you should not be there. And how can you become good enough to do this? You can only do this if this comes from a spinal level. If you're still at a level where you need your brain to think about it, you're gone, because on the day of the exam your brain will be gone. You cannot intellectualize. You can only do things that you've done a million times before. And if you've done a shoddy examination and a shoddy poor analysis a million times before, and you've only practiced 15 days or 20 days or a month before the exam for the hot cases, what will be unmasked on the day of the examination under the pressure and under the time trial is you will be found out. Your spinal level is bad and you will do a bad job. On the other hand, if you've done this a million times, you will find that it comes automatically to you. And where will you do it a million times? Not asking for hot case practice going and asking an examiner for a hot case practice. Do this in your ward round. And the hot case, if you think about it, is nothing but a ward round. Do you spend 20 minutes in your ward round? You don't. You spend less than that. Yet, if you do a good job, you should be able to come up with a good set of plans for your issues and plans for your patient at the end of the ward round. If you have a 20-bed unit and you spend 20 minutes per patient, your ward round will last 400 minutes. The nurses will hate you. Your junior doctors will hate you. You'll be doing a ward round from 8 o'clock in the morning till 4 o'clock in the afternoon till it's time to go back. So your patient with septic shock in bed 24 would have died by the time you reach him. You can give a good death certificate maybe. That's not what we want. So that's why the hot case is designed in such a way that it puts you under pressure. It tests what you've been doing in the past 5 years. A lot of good doctors have lost their way in 5 years. They don't examine, they examine they examine over the drapes, over the patient's gown. They auscultate over the patient's gown. They don't percuss. They don't piece things together. They don't really summarize the issues well enough. They allow their bosses to do it. If that's the case, how do you think you can get it in the spinal level? Okay. Now let's put this in practice. And the cases that I'll be showing you, I'll only be showing you one case here, but in the actual safe course, the cases that I'll be showing you are all patients that I have seen, and some of them actually were hot case cases in the exam. And there were a number of people who did well, but there were also a lot of people who did really badly. And once we go through this sequential deductive logic business, you will see how difficult it would be to mess this up. It's actually hard to fail this exam if you think about it. And I have to congratulate the people who find a way to fail this exam. So, the first case is somebody called Jane Smith. This was the scenario that we gave in the actual exam. 86-year-old woman. She was day 0, she was brought in post-operatively this morning. Initially the presenting problem was that she came to the emergency after a fall from a standing position. Initial GCS was 11, but then unfortunately she worsened, ended up getting intubated in the emergency, had a neurosurgical procedure, and then came to the ICU. Okay. Her background is that she's on warfarin and she's independent. The INR before the operation was 1.6. Actually, the INR on presentation was 1.6. She was intubated. Current status is that she's intubated and ventilated. This is a few hours after the operation, okay? She's intermittently sedated with small doses of fentanyl and propofol for non-purposeful agitation. And please assess for extubation. Okay, so let's go to the sequential deductive logic analysis. 86-year-old woman is the information. What are the implications of this? The implication is that she's an elderly woman. And although it says here that she was independent of all activities, the fact is that she is still elderly. So you do have to, that alters the prognosis, that alters your projection, that alters a lot of things that you would do. And you have to bring it in the discussion bit. Okay, it's day 0, so fresh post-op. So what are the various things? You can still have residual anesthetic or neuromuscular paralysis. You could still have acute post-operative complications such as bleeding and so on. Brought to the emergency after a fall from a standing position, which means it's trauma. But it's a low-level trauma. But in an 86-year-old woman who's fallen, you could still have spinal issues. And you could still have other injuries, especially for somebody on warfarin. So somebody who has fallen and clearly, if they've fallen, it could be because they've had a bleed in the head from the warfarin, or they now have a bleed in the head because of the warfarin, and you could also have bleeding elsewhere in the body because of the trauma. Initial GCS was good, but then not good, but altered level of consciousness, which was worsening, resulting in intubation. Why? Clearly, she's had some neurosurgical problem, and in fact, that is given away here, saying she was admitted to the ICU after a neurosurgical procedure. Clearly, therefore, she must have bled. And the bleeding, what neurosurgical procedure what could you do for an 86-year-old woman who's probably bled in the brain? What sort of bleeding? Could be extradural, subdural, and if it's an intracerebral hemorrhage, was it a clot evacuation or was it just an insertion of an EBD? Independent of activities of daily living, good. So good 86-year-old. And then long-term warfarin. What are the indications for warfarin that you'll think of? What are the common indications for warfarin? Atrial fibrillation is probably the commonest. Okay, atrial fibrillation. Or you can have mechanical valves, previous history of DVT or PE, some thrombotic state. These are the common indications. So go and look for them. Look for a surgery, okay, a sternotomy scar. Look for AF on the monitor, and so on. Still intubated, ventilated, so they were not able to extubate after the operation. So some problem. And intermittent sedation. You don't want to sedate somebody after a neurosurgical procedure, and they've already given away why, and it's because of non-purposeful agitation. So they want you to assess an agitated woman for extubation, and it's just after a neurosurgical, sorry, just after a neurosurgical procedure for which she was admitted to the ICU just now. Okay, that's it. Now, the end of bed examination. Okay, are there any significant infusions? In this instance, she's on a small maintenance IV maintenance of 40 mils an hour. Now, from the end of the bed, she seems to be roughly about 60 kilograms, sorry. She's about 60 kilograms and she's getting 40 mils of maintenance. Plus, she's getting about 7 mils of propofol and about 1 mil of fentanyl. So she is sedated with these two things. No obvious muscle relaxants, antibiotics, etc., etc. Then lines or tubes, as they've already told you, you find that she's intubated. The feeding tube, the nasogastric tube, is spigoted. So why are they not feeding? Is it just because she's acute post-op, so it's too early, or is it because they're thinking of extubating her, etc.? Okay, now therefore you can't talk of the feeds being tolerated. Good urine output for a 60 kilogram woman. Okay, there's no EVD, so that's one of the theories gone. There's no ICP monitoring or anything. Clearly, she doesn't have any other drains. There is a subgaleal drain on the left side. So, what surgery has she had? She's had a subdural hemorrhage. How much blood has come out? You ask the nurse, and they say 50 mils in the past 6 hours. So, good. Not much coming out. There's no back dressing or anything. Next, ventilator. Okay, you look for, sorry, before the ventilator, let's go to the monitor. Okay, for the monitor, she's having tachycardia with AF. So AF with a rapid ventricular response, no STT changes, so that's good. Her arterial blood pressure is good. Pulse pressure variation, you can't look for it because it's AF. So clearly, okay, I've ticked no here, but the actual answer is yes, but you have to say it's because of the AF. And then she's having good SATs, and we look at the FiO2 in a minute. What's the FiO2? It's 0.3. So good SATs with an FiO, so not much A gradient. So respiratory system, oxygenation at least seems to be okay. She's afebrile, the trend is the same, so good, that's no problem. And there's no real organ-specific monitoring such as cardiac output monitor and all that. Then the mode of ventilation, she's on spontaneous pressure support mode of ventilation with the pressure support of very, very minimal pressure support and very minimal PEEP, excellent saturation. Okay, so I've mentioned 98 here, 99 here, so excellent saturation. And then she's breathing very comfortably at 23 to 28 times. And the waveforms for the flow time waveform, the capnography and pressures are all looking good. So what it tells you is that, and the EtCO2 is about 35. So what it tells you is both oxygenation and carbon dioxide and ventilation and the pattern of ventilation and pressures and all that, compliance and all that, they're all good. So it means that most likely the respiratory system is not an issue for the oxygenation, for the problems with for the problems with the respiratory system. Okay, then the next is organ specific. There's no EVD, there's no ICP, so what you have is a subgaleal drain, but apart from that there's nothing. Clearly no dialysis, no card, so everything else is fine. Then finally finish off with the patient. She's appearance is consistent with age. She's an 86-year-old woman. She looks a little bit frail, but so what? All 86-year-old women will look frail, but she's not unkempt. She's not a drug addict or something. Then you notice something interesting. The right arm is restrained, but the left arm is not restrained. That's a hard sign. Why have they restrained the right arm? And she's also having non-purposeful movement of the left upper limb. So what does that tell you? Of the right upper limb. So what does that tell you? The left arm is not moving. So this tells you that she has paralysis, potentially paralysis of the left half of her body, left hemiplegia. Other things are not there. So you already have one hard sign from the 60 seconds or the 90 seconds that you're invested at the bedside. From the bedside, therefore, you know that she has some focal neurological deficit. The respiratory system is not an issue. The cardiovascular system, except for the AF, is not a big issue. There is a subgaleal drain. She's not being fed. The abdomen is probably not an issue. There's not much, and then she's being sedated for this non-purposeful agitation. So as I said to you, now these are the numbers that you got, but your job is actually to stand at the end of the bed or walk around the bed. And actually, as you're getting these numbers, you have to summarize. And so let's time ourselves. How long does it take to interpret and summarize the numbers? Okay. It looks from here that she seems to be stable from a cardiovascular system, except for the heart rate of sinus rhythm of atrial fibrillation with a rapid ventricular response. There doesn't seem to be any evidence. There does not seem to be any evidence of systemic hypoperfusion or shock. She's otherwise stable. There doesn't seem to be any evidence of right heart failure or anything. There is pulse pressure variation because of the AF, and there are no other monitors. So overall, I'm happy with the cardiovascular system. Overall, for the respiratory system, again, I find that everything seems normal. There's no evidence of hypoxemia, hypercarbia. She's having minimal ventilation support. The compliance is excellent. The oxygenation is excellent. Her breathing pattern is comfortable. Her respiratory rate is comfortable. There's no accessory muscle use. And the flow time curve, the capnograph, and is all that is normal without any evidence of expiratory outflow obstruction. So easy. Okay, and then end of the bed, she's okay. Now we come to the CNS examination. Now you have to go to the physical examination part, and you find she's sedated, okay, but with a graded level of stimulation. She was not alert. She did not respond to voice or firm touch, and therefore when I gave a painful stimulus, I found that she was localizing with the left hand, going for so she's localizing. She is not oriented. Okay. Then the cranial nerves, the pupils are fine, the corneals are fine, the cough and gag are fine. I couldn't do any other things. Now, under the motor system, she has an upper motor neuron finding, namely hypotonia, hyperreflexia of all on the right side. Sorry, I'm getting my sides confused because I'm imagining the patient. All on the side of the paralysis, sorry, the side of the paralysis is the left side. So all on the left side, she has hypertonia, hyperreflexia, clonus, and she has an upgoing plantar. Okay, right side seems okay. So she has a focal neurological deficit, which is a left-sided hemiplegia, and go back and say, okay, can I see a facial droop of the left side? Okay, and then I can't really examine the sensory system or the cerebellum, but there is a craniotomy which is on the left side, on the same side as the hemiplegia. So something like, okay, and there is some blood, but it's about 50-60 mils of blood. Now, the inconsistent findings are, now in the context of what I think is an acute stroke, she has very well pronounced neurological upper motor neuron signs. So something doesn't fit here because I would not have expected it on day 0. And also the craniotomy is on the same side as the hemiplegia. So again, that doesn't seem to make sense. I would have expected a right side craniotomy to explain a left side upper motor neuron paralysis. So something doesn't fit. Okay. An overall summary, the patient is sedated, but I have attempted an examination, and although my findings may be influenced by this and I'd like to stop sedation, I'm still going to present my neurological findings because I found enough to find a pattern. The CNS examination is consistent with an abnormal finding, which is consistent with a low level of consciousness, focal neurological signs, upper motor neuron signs of the left side, consistent with left-sided hemiplegia. Okay. And then the sensory and the cerebellar system cannot be examined. Inconsistent findings are that there is a craniotomy on the right side sorry, on the left side, which is suggestive of a subdural hemorrhage evacuation. So I'm not able to reconcile. So I'll have to ask myself, has she had chronic hemiplegia, which has resulted in an old stroke with upper motor neuron signs and old hemiplegia? But I was also told that she's actually independent. So that again, if she is hemiplegic, I would have thought that she would have had some level of dependence. So I'll have to go back to the history and ask the family about A, an old stroke, and B, the level of activity in the community. The physical examination of the CVS, evidence of shock. The peripheries are warm. Capillary refill time is normal. The endobedrogram, apart from the AF with a rapid ventricular response, was pretty good. No signs of right heart failure, and AF is the only special thing. On inspection palpation, it was all fine, and auscultation was normal with maybe an ejection systolic murmur that was radiating to the carotid, but there was no other parasternal heave, no signs of crackles, and so on. So what does this mean? It means as I'm actually doing this, I will have to say the patient is stable except for the heart rate of 120 without any evidence of shock or right heart congestion, but she has an aortic stenosis murmur, okay, but there is no evidence of pulmonary edema, pulmonary congestion, or pulmonary hypertension. RS, respiratory system, okay, there is no A gradient, there is compliance is excellent, waveforms are excellent, she's breathing beautifully without any major problems, chest examination is normal anteriorly, therefore my conclusion from the respiratory exam is that it's rather normal. The abdominal examination, there was no sign of chronic liver failure. The NG tube was capped, and I have to ask why. Is it because they tried it? Is it because it's too early? They haven't imaged the nasogastric tube yet or something? Or is it because they think the patient could be extubated soon and they want to keep her nil by mouth? On palpation, etc., I really didn't get any major findings, that it all seems normal, and bowel sounds were present, and once again that tells me that she probably doesn't have anything wrong with the gut, and the only reason they're not feeding is because there is, you know, uh, it's because she's being assessed for extubation.
Just to finish off, I'm going to focus on a few conditions that are very, very common in the exams. And there'll be a lot of repetition between these slides and the previous things that I said about focused examination, because ultimately the organ system is going to give you findings, and your job is to interpret those findings for clinical relevance. So fever is a very, very, very common problem, and fever is going to be the surrogate for sepsis. Okay, now obviously you'll have to remember that any fever can be both infective and non-infective, but you have to rule out infective causes before you think of non-infective causes. So non-infective causes therefore are a diagnosis of exclusion, and here's where all you have to do is a head. So when you have your patient with fever, it's a very, very simple examination. All you do is you do a head to foot examination of each of the organ systems and each of the limbs and so on, and that's it. And once you do this, you'll be able to get your cause for fever, or rather, if you're able to identify a cause, then that's how you will. And if at the end of all this, if you're still stumped and you don't know what the cause of the fever is, then you'll have to do this blanket, what is so-called septic screen. Now, one of the things that I'll keep emphasizing, I hate these so-called screens, okay? You never screen for sepsis, you never screen for vasculitis. You look for you do specific investigations first of all, you make an empirical diagnosis, and then you send off specific investigations that are designed to either confirm, or that is rule in or rule out your empirical diagnosis. If you do not have an empirical diagnosis at all, either you're a bad doctor or the patient is truly complex. But that step should be reached quite late in the piece. Okay, so for a head to foot, so let's talk about this. From the head to the foot, you have the neurological system, respiratory, cardiovascular, abdominal, then the renal system, and then you have I think skin and soft tissue and all that, which I haven't pasted here. Um, for neurological, what are the neurological causes of fever? or infective neuro. I'm going to talk only of infections here. Meningoencephalitis, brain abscess and all that, and the specific symptoms, these are all medical student level. So just read the slide if you wish. But the investigations, see how very few investigations here, okay? You do a blood culture, two sets of blood cultures in fact, for everything, all sources of sepsis, you'll do two sets of blood cultures, okay? And if you have something like line sepsis, etc., you have to say, I'll also do a set of cultures from the central line or from the vas cath or from the portocath or something like that. That is the minimum for every patient who has a fever. And then you do the specific body fluid. In this instance, you do a CSF, and then you think of specific imaging. And actually speaking, MRI, I've written it here purely because it's a potential thing for meningoencephalitis or brain abscess, but in the vast majority of cases your CSF will give you the result, and then you do an MRI, etc., only to either look for complications, or if the CSF, if you have a high clinical suspicion of a meningoencephalitis or a brain abscess and the CSF does not come back positive. Obviously brain abscess, you'll need to do a CT brain or an MRI, but remember, you have to say with or without contrast, and in this case you have to say with contrast. Respiratory, okay, you're not interested in the bronchitis and stuff like that. Pneumonia, and very simple, they present with a cough and purulent sputum, you'll have to look for bronchial breathing, okay? And then very easy, just for imaging, chest x-ray, looking for consolidation, microscopy and culture, two sets of blood cultures, and in this instance the specific body fluid is the sputum. Okay, you can say sputum, endotracheal secretions, BAL, whatever you want, but you want respiratory samples. Then you also send off for viruses. Okay, you send off for viruses, and then you send off for urinary antigens for Legionella pneumococcus. Now, if you tell me that you don't do these things on a regular basis for your patients, then I will automatically fail you. This is the minimum data set that you want for a patient with a suspected pneumonia. Okay, cardiovascular causes of infection of the cardiovascular system is actually extremely uncommon. Okay, and the maybe endocarditis is one of the things that you see as a when you have, it's an uncommon cause of fever overall, and it gets if you have a bacteremia, you can always get, especially with certain bugs, you can always have seeding of the valves and endocarditis. Some patients can present with primary valvular infections, especially if the valve is deformed or prosthetic or something. Now, acute endocarditis, in my opinion, it doesn't, apart from a fever, I don't think it has any specific symptoms, but you have to look for a cardiac murmur for both of these things. And then for subacute endocarditis, you have all those lesions, Janeway lesions, splinter hemorrhages, icterus, hepatosplenomegaly, and all that. And what specific investigations would you do? Once again, blood cultures, but in this instance, the specific body fluid is the blood. Therefore, you just keep doing blood cultures, and if the same bug keeps growing again and again, clearly you have to say there is a focus of infection somewhere in the body, potentially endovascular, which I have to screen, and you have to do either a transthoracic, and if the transthoracic doesn't show anything and the patient is still sick, then you have to do a transesophageal. Pericarditis and viral myocarditis. Now, pericarditis, the patient will come with pericardial pain, pericardial rub and all that, and ECG will have some non-specific changes. Echo will have a pericardial effusion, but pericarditis is one of those things where you have to make a clinical diagnosis because the investigations are not really specific enough, okay, to rule it in or rule it out. Then viral myocarditis, the patients can be really sick with viral myocarditis, and the main thing that it may end up producing is that you can have severe ventricular dysfunction for which you need an echo. The ECG itself is going to be non-specific. Biliary sources of sepsis, you can have jaundice and biliary tract signs and all that. You elicit signs of tenderness and jaundice, and the specific investigation is an ultrasound of the biliary tree, and of course you'll do microscopy and cultures of the blood. Gastroenteritis, colitis and all that from the gut. Okay, they'll have various different gut symptoms, diarrhea, dysentery and so on. You look for abdominal distension, you palpate for distension, tenderness and all that, and you do apart from blood culture, what is the specific body fluid here? Feces. Okay, and you look not just for bacteria, so microscopy and culture, but also for C. diff toxin for these patients. Now, imaging can be helpful, especially to diagnose complications so you want to know whether it's bowel obstruction and so on. You'll have to give oral and IV contrast, and if the patient has renal failure or something like that, then you'll have to say, depending on the renal, on the indication, I'll discuss with my radiologist and my surgeon, and if it's absolutely required, I'll have to give IV contrast, and then the questions can go then into contrast nephropathy, prophylaxis, and things. And once it gets into the zone, remember, this is your comfort zone. You've prepared a lot reading about contrast nephropathy, prophylaxis, and various other things. And that automatically takes you to a nice, comfortable level where you can have a nice theoretical discussion on all of these things. Okay, now you can do endoscopies, biopsies for looking for pseudomembranes and all that. But in general, the stool culture and C. diff are and blood culture, of course, is what you're going to do. Then if you have a bladder infection, if you have a renal tract infection, then you could have cystitis, pyelonephritis, and even prostatitis and so on. What do? You get blood cultures, but in this instance, a specific body fluid is urine culture. And then you elicit or you look for signs of renal angle tenderness. And if it's things like prostatitis and so on, if the patient has persistent, is not getting better, then always, even clinically, do a PR, palpate the prostate, make sure that it's not tender, etc. Okay. The specific imaging technique for kidney tract is an ultrasound of the renal tract or CTKUB, looking for pyelonephritis, so stranding around the kidney, obstruction of the kidney, stones, and so on. Then, skin and soft tissue infections are also extremely common, and they can be anything from just superficial cellulitis to necrotizing fasciitis or deeper tissue infections such as myositis. And the important thing you have to say is that I will have a low index to suspect this because the superficial skin may be completely intact. So it'll be you'll have to feel for the compartments. You'll have to just look around. You'll have to make sure there are no bullae there, and then feel for crepitus, for gas under the tissues and so on. And again, the specific imaging in this instance will be an ultrasound or CT scan. Of course, you do a blood culture, obviously, for this, but you do an and you might do some swabs sometimes. But you do an ultrasound or a CT scan looking for gas in the tissue planes or derangement of the tissue planes and collections and so on that you can drain. And then CK you have to do for if you're suspecting myositis. Neck, you can have deep neck space infections and all that. And again, you can have various upper airway symptoms, upper, dysphagia, the 4 Ds of the midline abscesses. And here you inspect, palpate, but you're very limited from the end of the bed. You have to do, sorry, I forgot to mention, you have to do a nasoendoscopy to go and inspect the tissues from the inside, and then you have to do a CT scan of the neck with IV and oral contrast. Okay, so very, very easy. If you have a fever, firstly do the endobedogram, and right from the endobedogram onwards you can easily have several clues to the focus of sepsis. So as I said before, if you have low compliance on the ventilator, and evidence of high oxygen requirements, though maybe it's a respiratory source. If they have had abdominal distension from the end of the bed and they're tender, then go there. Okay, look for the skin, soft tissues. Then if you find nothing there, or then you have to say, I'll do blood cultures, and then since I don't have anything, I'm just going to do screen or the cultures of the body fluids. Of course, I look for lines. Line sepsis, something I haven't mentioned here. As far as line sepsis is concerned, you have to make sure you inspect the site. Okay, but even if the site is okay, you'll have to say, I'll have a low index of suspicion. I'll do cultures from the line and blood cultures, and if my lab has it, then I'll do quantitative cultures and look for the differential colony count. And if not, then I might time them. So I might give them at the same time and see which one grows first, and all of these things. Okay, very, very easy. Now, extubation, this is an extremely common question that you'll always be asked in exams. Okay, hot cases. Can you extubate your patients? And extubation is a 2-step process. The first step is weaning off the ventilator. So you get rid of the ventilator, which means the patient is essentially not requiring the ventilator for artificial breathing support, so they can breathe on their own. But the next step is, can you get the tube out? Second step is to get the tube out, and that the acronym for that I have is PowerPoint or PPT, which is airway patency, airway protection, and toilet. Okay, so you may be able to get the ventilator out, but if a patient remains unconscious and is unable to have unable to either protect the airway or have a patent airway, or you can get the ventilator out, but the patient has a large swelling in the neck, from a submandibular parapharyngeal abscess or something like that, which is now causing again patency and patency issues. Again, you can get the ventilator out, but it's a little old lady who can't cough and therefore can't clear their secretions, and tracheal toilet is a problem. All of these things. Okay, so as far as extubation is concerned, just getting the tube out, it's just these three things that you have to ask for. What are the various factors that determine airway patency? So it's essentially from neurological causes, so level of consciousness, okay, and then something neck compression issues and so on. So this is patency. For protection, once again, you need to be conscious, and then the brain needs to send out a cough impulse. So you need to have a good spine, all the nerves should be working, and then the muscles of respiration should be working, and the lungs should be able to take a really nice deep breath and and mount an effective cough. So protective airway reflexes and the muscles to actually cough it out. And finally, toilet. If you always ask for how much endotracheal secretion is coming out, and if they say I'm sucking out secretions every 10 seconds, clearly it's not compatible, especially if it's a little old lady, etc. So you'll have to say, I'll be concerned about this. I'll probably find out why the patient has so much secretions, treat that, and then get back to, and then maybe get the tube out. Okay. Now, weaning is a very easy thing. Again, what are the various causes why you're not able to liberate the patient off the ventilator? Okay, is it because of cognitive issues, they're very drowsy, or neuromuscular weakness, so they're not able to take a good enough breath, so every time you put them on a spontaneous breathing trial, they fail, becoming tachypneic? Cardiovascular, are they having a low cardiac output state, or heart failure, which again, as soon as the positive pressure is removed, the afterload increases, the preload increases, and they're not able to cope with it? Then respiratory system, you can have any cause where you have restriction of lung expansion, so pleural effusion, or obstructive lung. So I've mentioned pleural effusion here, but obesity is another thing. Okay, or poor chest wall complaints or something like that. They're uncommon. Then more common will be obstructive lung diseases, obstructive airway disease, and neuromuscular causes, going back to this above. Okay, fluid overload again is an extremely common cause. Ongoing sepsis, if a patient has low-grade sepsis, they're having a hypercatabolic state, again burns or sepsis or pancreatitis or anything like that. Nutritional, you can have deconditioning, so you inspect for muscle wasting and so on. So clinically at the bedside, what do you do? For each of these things, I've listed the most important things you have to do. So when you want to assess somebody for weakness, you have to make sure that they have anti-gravity power of their proximal muscles, and the neck muscles might be useful, and do a vital capacity breath. If you don't do the minimum data set, how can I convince myself that you're safe? Okay. Then if you ask for investigations for this, there is nothing specific. It's all at the bedside. Then because you have ICU acquired muscle weakness as a possibility, you do the deep tendon reflexes. If they have hypotonia and low motor neuron paralysis, then you can say maybe this is ICU acquired weakness, myopathy or neuropathy or so on. You can maybe say I can do nerve conduction studies and so on, but again, they're not going to be really useful they're not going to add much value. You can mention it. Brain imaging, etc. Not again, you can say I don't expect any abnormality, but I'll just make sure that he has no structural lesions in the brain by doing a CT scan, non-contrast CT scan of the brain, or non-contrast MRI of the brain. For the CVS, echo is the specific investigation, just one single thing that you can say, but looking for what? Looking for RV and LV function, okay, and signs of pulmonary hypertension or something. For the respiratory system, you'll get a chest x-ray, but if the patient has been in the ICU for 10, 15, 20 days or something, better off getting a CT scan. In this day and age, I do lung ultrasounds quite a bit. I like that. And then at the bedside, these are the things that you have to do. Okay.
Then for fluid overload, again, I don't think there's any single test that you can do. Investigation, I just look at the fluid balance chart and then look clinically to look for signs of hypervolemia. Ongoing sepsis, again, septic screen. You know that word that I hate? Now, therefore, do a focused septic screen. So in this instance, if the patient, if at the end of the bedside examination, you found that he has a pneumonia or abdomen is distended or something, go for that organ. So say, I'm worried that there is ongoing sepsis in the chest or abdomen, therefore I will get a chest x-ray, sputum cultures, blood cultures. Okay, blood culture for everyone. Okay, so maybe blood culture, sputum culture, chest x-ray, looking for this, or CT scan of the chest with contrast, IV contrast. If the abdomen is distended or something, you'll say blood cultures and then look for liver function test, looking for cholestatic picture or something like that. And then imaging will be a CT scan of the abdomen with IV and enteral contrast. Okay, all of those things. Then ongoing inflammatory state, if the patient has a pancreatitis or something, you have to say, I have to be guided by the imaging. And the operative findings, what did they find last time? So if you know the patient has gone for surgery and come back, just say, I want to know what happened. What did they find? This is not, we are not going to hide anything from you. We expect you to ask. If you don't ask, we won't tell. But if you ask a proper, sensible, specific question, that's what we are here for, to give you that proper, specific, sensible answer. And based on that, you then go to the next level and give a proper, sensible, deductive logic assumption of what might have happened to the patient. Then nutrition and deconditioning, you look for nutritional assessment, get a dietitian. It's something that I don't really believe in, albumin, pre-albumin, those kind of things. So finally, some of the other conditions that you will commonly see. Remember, the hot case is done in actual hospitals on actual patients. So these are the patients that you will encounter, that you will see, are the patients that you see every day in your ward round. Okay, remember that the best training for the exam is your ward round. If you apply your mind, if you make sure that your processes in the ward round are good, a good practice will become your normal practice. Okay, so when you see your patient with shock or hypoxia, liver failure, trauma, reduced level of consciousness, and if you have your complicated surgical patient or something, apply your mind. What is the problem that I'm having? So that is your stem. What are the issues that I want? So that is what you have to get from your endobeddogram and your physical examination. What investigations do I want to do? Don't go to your investigation list and just ask your resident to tell you all the investigations. Tell the resident, please look at the chart and tell me what the blood cultures are, whether he's had blood cultures. What is show me the chest x-ray, show me the liver function test specifically for LFT is not, it's a screen. I want to know what the transaminases are doing. I want to know what the cholestatic enzymes, the bilirubin and the ALP, GGT, what are they doing? That kind of thing. Tell me what the lactate is on the blood gas, or tell me what the PaO2 is and what's the FiO2 on that. If you actually apply your mind like that on a day-to-day basis, a good practice becomes your normal practice. And if it becomes normal practice, what do you have to fear on the day of the exam? Okay, you only have to fear the exams if your normal practice is not good. And honestly, if your normal practice is not good, you should not pass the exam. You should fail. That is what the exam is meant to do. It is meant to determine whether or not you practice well and you practice safely. And if you do not practice well or you do not practice safely on a day-to-day basis, then just on the day of the exam, if you end up either becoming lucky or becoming, if you play the game or something like that and you pass, that is a failure of the exam process. We should find you out. Okay, if you ask yourself an honest question about whether you would like to be treated by an intensivist who is not practicing good medicine but just knows enough of exam technique and ends up passing the exam, would you be happy? If not, then that's exactly what the exam is meant to do. We are supposed to screen for trainees who've been practicing a good level, a good standard of intensive care medicine for a long time, and the exam is structured in such a way that everything that we do is towards testing whether you do a good ward round. If you end up doing a good ward round, believe me, this exam is actually very difficult to fail. So now putting it all together and making issues, clearly she has a CNS issue, which is a right-sided subdural hemorrhage with getting the issues wrong. The side wrong. Left-sided subdural hemorrhage with something that's inexplicable for you, which is a upper motor neuron type of weakness with a hemiplegia. And also an altered level of consciousness, which is agitation, which is non-purposeful agitation, and you have to now think of all the differential diagnoses for that. The cardiorespiratory, she has an AF, which is old with a rapid ventricular response, and she is on warfarin for the AF. But otherwise, the cardiovascular system is normal, respiratory system is normal, abdomen system is normal. So this is an essential, this is main, and the reason why she cannot be extubated, remains intubated now is because of the fact that she hasn't really woken up after a subdural hemorrhage, although she has had an she's had it evacuated. What will you do now? Now you go back and ask yourself, what are the specific investigations for each of the issues that you have uncovered? And that's how you go forward. Now, in the next segment, the next video, I'll explain where to go forward with this. Now that you have got all of these issues, it's now time to investigate and treat and further summarize. So that will be a separate video. All the best.